Right, it's time to think about the recipe for success when it comes to emergency anaesthesia. It's a great topic to think about because everything we're covering here is looking at how we can make life as easy as possible with regards to intubation and optimizing our patient's physiology and outcomes. And there is so much we can do with our selection of drug regimes that can help with this. So in a rapid sequence induction, the anaesthetic that we're giving is going to be in an unfasted, critically unwell patient. And because of this, we're looking to achieve a few things rapidly to help optimize the outcomes that Rob was alluding to earlier, which are optimizing their physiology, or rather not ruining it, and delivering the anaesthetic triad of amnesia, analgesia, and muscle relaxation. These are closely intertwined, and it's worth thinking about the typical cases we're going to see in an emergency. A lot of the patients we're anaesthetising are already unconscious, be that post-ROSC, from a head injury, from a type 2 respiratory failure, etc. So the anaesthetic aim with hypnosis or amnesia isn't going to necessarily be the same as for the elective list that you've got in theatre, where the patient might be bright-eyed and bushy-tailed before you start. In terms of analgesia, the patient may well have had some pretty strong pain relief already that has affected their conscious level, be that opioids or something like ketamine, which may have dissociated them to some extent already. So for me, I very much look at the patient in regards to where are we? What level of anaesthetic has the patient got on board from the event that's happened, and how much further do we need to take them? You could ask, well, why are we trying to get away without a full anaesthetic? After all, we're not paying for the drugs that we're giving the patient here, but the trade-off with many anaesthetic agents is the physiological impact that they can have on the patient, and some agents, and specifically big doses, will make the risk of physiological deterioration more likely. So we need to pick well and dose wisely. We need to be aware of those agents that are negatively inotropic and those that cause significant vasodilation. Lastly, we need to paralyse our patient here because we're going to be passing a tube. We want the vocal cords paralysed and open, and we want the tone of the upper airway to be as relaxed as possible to give us the greatest opportunity to gain a good view at laryngoscopy. So we're going to want to pick the paralytic agent that can provide this in a reliable fashion with the least side effects, and can be used for simplicity to provide ongoing paralysis for the anaesthetic if possible. So to recap, when we're putting someone off to sleep in the context of an RSI, we're going to be giving an induction agent to rapidly get them off to sleep and a rapidly acting paralytic agent that can optimise the intubating conditions as quickly as possible. We're trying to pick agents that not only achieve this, but can ensure the physiology is optimized. And so we might also want to add in another agent that can help us reduce the amount of induction agent to limit their unwanted effects. So we're thinking here about things like opioid analgesics and benzodiazepines as co-induction agents. Now, this certainly isn't the most in-depth talk about pharmacology that you're ever going to sit through, but the idea is to give us an opportunity to think about what might be used, the sort of dose, and why. So starting with the induction agents, the ones that are most commonly used are ketamine, which is useful in hemodynamically unstable patients. Previously, though, it was thought to increase the patient's ICP, so concerns about things like head injuries, but that's now not proven to be true, so we don't need to worry about that. The adverse effects you can get with it, well, it can cause secretions, tachycardia, and hypertension. It works pretty quickly, so an onset between 60 and 90 seconds. It lasts around 20 minutes, and the dose is 1.5 milligrams per kilogram. Next up, propofol. So this is useful in hemodynamically stable patients, and it's a good anticonvulsant, and actually ketamine has some anticonvulsant effects as well. The problem with propofol, and you'll have heard people talk about this, is the problems regarding inducing hypotension. So it's a myocardial depressant and causes vasodilation and therefore hypotension. It works quickly in just over half a minute, and the duration is between 5 to 10 minutes, so it switches off pretty quickly. And the sorts of doses we're looking at here, and this is for a stable patient, is going to be between 1 to 2.5 milligrams per kilogram ideal body weight. The last induction agent to mention is midazolam. Now, this might be useful in some post-ROSC patients. The adverse effects here again are some hypotension. Onset, slightly longer than propofol, 60 to 90 seconds. Lasts a bit longer as well, with a duration of 15 to 30 minutes. And the dose, around 0.3 milligrams per kilogram IV total body weight. Now, mentioned a second ago, co-induction agent. So something you can give to reduce the amount of induction agent that you might want to give or to bring in added effects from it. So these are mainly opioids and most commonly fentanyl. Now, fentanyl can be used as a sympatholytic pre-medication for traumatic brain injury. So giving it a couple of minutes beforehand to help attenuate that sympathetic response and to try and stop that spike in intracerebral pressure. The adverse effects, well, you can get hypotension, and often in patients that you're giving fentanyl to, you'll see some hypotension just after induction and intubation. Now, the onset is 1 to 5 minutes and the duration is up to 30 minutes, which can be even longer than that at higher doses. And the sort of dose that we're talking about here is 1 to 3 mics per kilogram in total body weight. On to paralytics. So this has been a big change in practice over the last decade or so, moving from the depolarizing suxamethonium to the non-depolarizing and longer-lasting paralytics like rocuronium. Initially, there was a lot of enthusiasm for suxamethonium as it only lasts a few minutes, and if you couldn't intubate the patient, you could then wake them up because it wasn't going to have that paralytic effect ongoing. But in the context of what we're talking about here, the critically ill patient that needs intervention, then actually that's not really an option because you pass the point of return. And there's also, with Sux, quite a few side effects to think about. So it's contraindicated in hyperkalemia, malignant hypothermia, burns and crush. The dose is 1.5 milligrams per kilogram IV or 2 milligrams per kilogram if they've got myasthenia gravis, and 4 milligrams per kilogram IM in extremis. Onset, in front of your eyes, you'll see it happening 45 to 60 seconds, and the duration is several minutes. So rocuronium is an alternative, as we've mentioned, and it's probably the most commonly used paralytic agent in this context in the UK at the moment. At decent doses, its onset of action is within about 60 seconds, which is what we'll come on to about the amount of time we wait from giving the drugs to then moving to intubation. But if you give it at lower doses, then that's going to take longer for that onset of action. But it lasts a lot longer than Sux, with paralysis of up to 30 to 45 minutes, which is well worth thinking about because that's going to affect when you need to give a second dose of a paralytic agent. You use a dose of around 1.2 milligrams per kilogram IV of ideal body weight. It's contraindicated in a couple of cases, but pretty rare. So that's with people with an allergy specifically to it, and it can be reversed, although it's a bit of a faff doing this, with Sagamodex.
All right, nicely done, Simon Lang. But hang on for a minute before you disappear off. It's probably time to pull all of those drugs together now. Are there any formulas or standard recipes for an RSI that we could follow?
I thought I was doing all right for an ED physician, just keeping it fairly accurate with regards to the drugs. But you're asking me to combine it all together, so this is going to be really testing me. Well, joking aside, hopefully, people will probably have heard about 3-2-1 dosing, and that's with regards to fentanyl, ketamine, and rocuronium doses when it comes to an RSI. This came from a paper published by Lyon and colleagues from KSS, I think in 2015, and was for pre-hospital anaesthesia of trauma patients. And the 111 was what they used in a reduced dose for hemodynamic compromise. So when saying 3-2-1, what I mean here is 3 mics per kilogram of fentanyl, 2 milligrams per kilogram of ketamine, and 1 milligram per kilogram of rocuronium. So that's how it's then abbreviated to talk about. So with this 3-2-1 and 1-1-1 regime, they then compared that to a combination of etomidate and Sux. And that was in terms of intubating conditions and hemodynamics in an RSI. And what they found was actually this 3-2-1 or 1-1-1 produced better intubating conditions and better hemodynamics in the pre-hospital environment for trauma patients. And I think what that's then led on to is a really nice way to think about a recipe for an anaesthetic. But it's not quite that simple, because from that, there was a reasonable amount of discussion and concern about the risk of hypotension, especially with regards to fentanyl, because we know that hypotension surrounding an RSI is associated with an increase in morbidity and mortality. And then maybe we should try and attenuate that fentanyl dose for these patients. Now, this is a great table from Luck and Morgan in their publication of 2019, which is based upon the work of Miller. And I'd suggest you come back and have a look at this at a later date and really familiarise yourself with the sorts of things we're talking about here, because I think this is a great table and really represents the sorts of things we're thinking about here when considering the trade-off of agents and dosing of them with regard to the patient in front of you. Now, this is obviously just a recipe including fentanyl, ketamine and rocuronium, and there are loads of other recipes and combinations you can go for. But thinking simplistically here, keeping agents the same and familiar to all of those involved in these emergency situations, and building off a basis of the patient in front of you, thinking about a 3-2-1 and 1-1-1, and then attenuating it to the needs of that situation, that patient, is probably a really good place to start.
There you go, Simon Lang. Terrible chef, but much better emergency physician. So yes, take that recipe as you will. Now,
That's no compliment in there.
There was somewhere within it. Now, you also mentioned within that talk that ketamine might cause that patient some hypertension and tachycardia. So with those patients who are going to get an anaesthetic following a ROSC from their arrest, would midazolam not potentially be a safer option than ketamine, given the likely underlying cardiac cause?
So I always thought that would be the case, and I certainly had avoided ketamine in those post-ROSC patients that I thought would be susceptible to the side effects of ketamine and maybe precipitate another cardiac event. But then there's been a great paper again that was published by King in the EMJ looking at this topic. So whilst it wasn't an RCT, they looked back over their ROSC patients who Essex and Herts Air Ambulance attended who required a pre-hospital anaesthetic. Now, there were about 200 patients over a 5-year period, and they were looking to see if there was any difference in associated hypotension within 30 minutes of their fear, dependent upon whether or not they were given midazolam or ketamine. And they found no significant difference in hypertension rates or maximal heart rates. I think the caveat here is to say that this is a mixture of doses and a mixture of strategies. So this isn't a definitive RCT to answer this question, but I found this paper really useful to go and have a read of, and certainly have influenced me towards being more comfortable with the idea of ketamine in those patients who we're performing an RSI for post-ROSC, be that in the pre-hospital or the in-hospital environment.
Nicely answered. Yes, nicely answered. It is something that comes up fairly often, that question. So last one from me. Those recipes that you've mentioned work really well for that compliant patient who's sitting there nice, well-behaved, and is going to comply with their pre-oxygenation. But of course, every patient isn't like that, are they? Let's say a head injury patient who is extremely agitated. Is there anything we can do pharmacologically to sort them out? Rather than us chasing them round resus, hoping to get some drugs into a cannula to then put them in a net and catch them and put them back on the bed to get the tube down. So is there anything else we can do?
As much as I'd love to see you in that Laurel and Hardy sketch doing that, it's probably wise, isn't it, to come up with a strategy for this. So I guess what we're alluding to here is a delayed sequence intubation. And this is something that has come much more into practice over the last 5 to 10 years. So Scott Weingart first published on this in 2014 in the Annals of Emergency Medicine. And this was a prospective observational multi-centre study of patients who were a bit of a challenge to pre-oxygenate because of their delirium. It was a convenient sample of ED and ICU patients who got a dissociative dose of ketamine to allow them to be pre-oxygenated with a high-flow non-rebreather mask or non-invasive positive pressure ventilation, and were then RSI'd. And what they were mainly looking to see was the difference in oxygenation saturations after their best attempts of pre-oxygenation had been given without the ketamine, and then having had it to try and dissociate them to pre-oxygenate them. And the results they found were pretty powerful in that they saw the mean saturations increase from 89.9% to 98.8% with the use of that ketamine for dissociation before then going on to give the rest of the drugs. So for that patient that you're running around recess for, Rob, trying to get a bit of ketamine into them to calm them down, maybe a dose sort of 20 to 40 milligrams to start with for a reasonable sized adult, and then maybe a bit more if it's needed. Optimize their physiology, pre-oxygenate them, and then, as we say continually throughout this course, this is all about making the next step easier. So get a really good reservoir of oxygen into their lungs, then the ability to perform a slick intubation without any physiological compromise is going to be much improved.